Good day, everyone. My name is Jennifer Willis, and I will be presenting on congestive heart failure studies. This was done by Lisa Jones, myself, April Cobbs, and Juliana Rodriguez. Congestive heart failure is a serious medical condition in which the heart cannot pump enough blood to meet the body's needs. The causes of congestive heart failure include hypertension, diabetes, or coronary heart disease. Some facts about congestive heart failure is that more than 5 million people in the United States are affected by congestive heart failure, and it is one of the most common causes for hospitalization for those that are 65 and older. Congestive heart failure has been identified as chronic, progressive illness with a 5-year mortality rate. Accounts for 287,200 deaths and more than 1 million hospitalizations. Incidences of congestive heart failure was tripled in the past 2 decades, and there are 550,000 new patients diagnosed every single year. We did a literature review on 3 different studies. For our first study, the research question was the difference in quality of care provided to congestive heart failure patients by model of care, whether it was PCPs, nurse practitioners, or both. The data was pulled from Medicare claims to help describe the process and outcomes of care. The results include patient care for by nurse practitioners had fewer provider visits and slightly lower continuity of care, but were more likely to receive specialist consultations for cardiologists than those cared for by PCPs only. Patients in the Share Care group had more provider visits and more cardiology referrals than those in the PCP group. Patients in the nurse practitioner care model had a lower rate of emergency room visits and hospitalizations. Shared group had more emergency room visits and hospitalizations. Based off of these results, congestive heart failure patients under the Share Care model should visit clinics more frequently to help avoid recurring hospitalization and emergency room visits. This second study's research question was to determine the gender difference in one or more survival and quality of life among patients admitted with congestive heart failure. A questionnaire was given to 435 patients that were admitted between 1993 and 1994 at an urban university hospital with shortness of breath, fatigue, and evidence of congestive heart failure. Additional questionnaires were sent out 2 months after the patient was discharged and then again at 1 year. The results were 106 of the patients died regardless of their gender. Women had less improvement than men out of the survivors. Women survived longer but had lower HRQOL. Overall, the study determined that there is not a gender difference in 1-year survival and QOL among patients admitted with congestive heart failure. In the third study, the question was telehealth protocols to prevent readmission among high-risk patients with congestive heart failure. Random sampling was used to recruit 50 patients with congestive heart failure from a managed care organization with 1 emergency room visit in the last 3 years. Video conferencing was done daily, and then there was a multiple choice questionnaire. Admission and readmission rates were compared between 6-month periods. The results to this study is there was no significant difference in adherence by patient characteristics or in admission or readmission for patients during the intervention period versus the comparison period. And telehealth can reduce congestive heart failure related admissions. Our study we conducted was congestive heart failure and emergency room visits. The method we used was a MedPAR data set distributed by Centers for Medicare and Medicaid Services. There were 390 individuals with congestive heart failure that were admitted in 2009. Our research question is there any association between gender and admission source from the emergency department? The null hypothesis is there is no association between gender and admission source from the emergency department. The alternative hypothesis is there is an associating between gender and admission source from the emergency department. Analyzing the data. A pie chart allowed us to show the admission source by number and percentage. As you can see on this chart, 36% was physician referrals, 2% were clinical referrals, 11% were transfers from the hospital, 5% were transfers from a skilled nursing facility, 2% were transfers from another healthcare facility, and 45% were emergency room. A bar chart displayed the male and female ratio. So you can see based off of the chart that males there was 198 and females 192. A chi-square test was conducted. The results of the chi-square test indicated there was no significant relationship between gender and admission source from the emergency department. Since the p-value was less than the alpha, we failed to reject the null hypothesis. The limitations of this study was the sample size, demographic area, and only individuals who wished to participate in this study. Thank you so much for listening to my presentation, and have a great day.